And on that note, let me get started for today's webinar, which is the third of the series from Dental Routes webinars. And as I was speaking to Center, I think you could have caught a bit of a note on what's going on everyone's mind. And that's probably what I'm thinking of reflecting for the first few minutes while we're catching up with all the other people who are trying to log in. So what has lockdown done to us? Obviously, one good thing I can elicit out of it is it's given us so much time to relax, which is amazing. Probably I've been doing this job of a dentist for a couple of decades now, and I can never remember a time when I got so much time to relax. But while relaxed, it also gave us a lot of time to reflect upon how things has been over the last whatever number of years we have been practicing dentistry. We all know future, which is in so many ways uncertain. So we need to rethink our strategies and then start to plan changes we need to make to accustom ourselves to the new normal. And so these are the three critical words I sort of started to emphasize on, which is reflect, rethink, and plan for the changes we need to bring in. On that note, I'm sure one thing that's not going to change is the expectation of our patients. And when I think of a potential customer, as we go back, mainly with high treatment needs, one thing that strikes to me is a popular quote from Mr. Winston Churchill, when he says, and I quote, "I'm very easily satisfied with the very best." Yeah. And this is more or less what we tend to hear from all our patients as well, but in a bit of a split way. When you're first seeing them or the first initial consultation and things like that, the kind of a signal you see is that I'm very easily satisfied. But as I start to go into the treatment and come to the fag end of the treatment, you will be able to elicit the last part of the sentence, which is with the very best, which basically means we got to be that very best to make sure that we can easily satisfy our patients. Hence, we at Dental Routes have always tried to bring all of our members the very best in the business. And this has been and will always be a promise to all the guys who keep coming back to us for more information. We have been working extremely hard behind the screens. There's a lot of guys who have brought in a lot of hard work to bring in the content that we are trying to bring in. Today on the panel, it's me, Kaushik Naik. I'm a dentist who's one of the directors of Dental Routes. And we also have Dr. Senthil. He's the other panelist who will be there helping us out in terms of trying to get the questions out and see what kind of a very mutual discussion-based webinar this can be made into. And for us, it's all about trying to be very interactive and get all the questions up from all the spectators and viewers today. On that note, I take the opportunity to introduce our main person, who's our speaker for today. And that is, we had the privilege to invite Dr. Tarun Kumar, and he has gracefully accepted our invitation. I will tell you a few things about Dr. Tarun Kumar. There's a massive list. I will try to shorten it as much as I can, because everything is so amazing when I was reading about him myself. So Dr. Tarun Kumar is considered one of the leading authorities in bone regeneration internationally. He is a specialist in periodontics with extensive work in the field of clinical research in advanced dental implant therapy with bone and soft tissue reconstruction techniques. His special focus has been on bone regeneration using different bone graft materials, growth factors, and barrier membranes. And he has been the founder and academic chairman of the Bapuji Implant Center, and he is also professor at Bapuji Dental College. Tarun is a fellow and diplomat of ICOI and fellow of World Academy of Ultrasonic Bone Surgeries. He is awarded the expert implantologist from European Association of Dental Implantologists. His lectures extensively worldwide and has published over 50 articles and book chapters. He is assistant editor for International Journal of Oral Implantology and Clinical Research. He is also on several editorial boards for scientific journals. Dr. Kumar is an active member and lecturer for ISOI, the American Academy of Implant Dentistry, International Congress of Implantology, European Alliance of Dental Implantology, to name a few. He teaches current concepts in implant protocols globally. He is the course director of ICOI implant programs, and he is also the faculty for Foundation Implant Program at the University of USA. So guys, this is a very, very shorter version of the things that he's done. And I probably think I can always give you a webinar just on this aspect. But having said that, the most I'm at is just to start. And with no time spared, I'm gonna push the street over to Dr. Tarun Kumar. Thank you very much, Tarun, for coming. How has things been in India, and how are you doing today?
Good, Kaushik. Good to hear you and good to see you all. You know, it is crazy times now. Everywhere it is crazy. We are all shut from past 55, 60 days. So going back to work probably next week, we are seeing how difficult it will be to start working routinely in our practices. So
yeah,
it's
yeah,
difficult times.
Yeah, at least you guys are showing a bit of a light end of the tunnel. It's all about trying to pull our stocks and getting business usual, but probably with some changes. And I was looking at some of the things that you're trying to speak to us about today. You're trying to keep it basic to all the general dental practitioners. So we are very thrilled and excited, Tarun. So yeah, I'm looking forward to this session.
Okay, Kaushik. Thank you very much for having me in Dental Routes for this webinar. I know this during this crazy times of lockdown, people, you need to sharpen your axe so that when you go back to your practices, you know something more, and you know you need to have knowledge to do something new in your practices. So these kind of webinars have always helped a lot of dentists across the world. People say that there has been so many webinars, but to be very frank, every week it keeps us engaged with such a good knowledge happening at our homes. And thank you, Kaushik and Senthil and Pratap for having me to deliver a webinar. And thanks, Kaushik, for that kind, long introduction of me. Let's get started with the webinar. Today, I'm going to talk about guided bone regeneration, some of the concepts and techniques which is involved with this particular technique, because as we know that many general practitioners are getting into implantology. And as we get into implantology, it is not just about placing the implant. We also need to know how to grow bone and soft tissue around implant, because as we put more number of implants, we are going to have a lot of deficient situation, lot of complex situation where we need to understand what is bone and how to regenerate this, because now as we learn more about dental implant, we learn the biology. We are understanding that it plays more role of bone regeneration is required, more knowledge and clinical experience is required of regenerating bone. Now, as we know that we have come away from bone-driven implant placement from the when it started in 1965, it was basically a bone-driven implant placement when Brennamark placed his implant. But today, since we have been replacing implants in the anterior maxilla aesthetic zone, it is more of prosthetically driven implant placement. Today, we are doing planning in our CBCTs. We are planning our restoration before even thinking of placing an implant in the bone. That means to say that we are more of prosthetically driven. Along with that prosthetically driven restoration and implant placement, what comes in is whether we have bone in that area to place the implant in the right 3D position. So today we are going to place the implant in the right 3D position. That is mesiodistally, you should be 1.5 to 2 millimeter away from the adjacent teeth, apicocoronally around 2 millimeter from the CG of the adjacent teeth. And buccolingually, you know that it should be within the emergence of the adjacent teeth. And to have these three-dimensionally perfect position, you need to have bone in the right places. And that is the issue we need to think of. And that is where we have problems when we trying to place the implant in the right 3D position. Now, what is the problem? The problem lies is when we extract teeth, we are going to lose bone. We are going to have shrinkage of bone. And we now know that in the first 3 months itself, we have significant amount of shrinkage of bone. So when we come back to place our implant after 4 months, we will see that we don't have that ideal bone condition to place our implant. So what next? We need to understand that we need to place in our head that there is going to be shrinkage of bone. This is one of the study which is published, I think, which is one of the most cited study in extraction socket healing after implant came into market. That is from first week to 8 weeks. If you see, the buccal bone is going down. That means the buccal bone is shrinking and getting lost in the 8 weeks period. And it is proven multiple times with various studies that the bone loss is going to happen, whether we are going to place an immediate implant or not, whether we're going to place some graft into the socket or not, we might end up having shrinkage of the bone. Now, the thing is, how this bone loss is related to the buccal plate. Now, that is dependent on the thickness of the buccal plate. So there is a study by Buser's team where they did a study of thickness of the buccal plate and resorption pattern. So they came up with a magic number. They said that 1 millimeter is a magic number. If the thickness of the buccal plate is more than 1 millimeter, that means the resorption or the shrinkage is less. Whereas when the thickness of the buccal plate is less than 1 mm, then you are going to lose all of the buccal plate up to 8 millimeters. So that means 8 millimeter of vertical bone is going to be lost in the first 3 to 4 months, right? And so we might think, okay, if you have 1 millimeter bone, we are going to be safe. The thing is now, the second question, how many people do have 1 millimeter and more than 1 millimeter bone? If you see the study again, 63 to 80% of the population have less than 1 millimeter. That means, so all this population which have 1 millimeter and less than 1 millimeter bone is going to have shrinkage of the socket. So we need to think, when we remove teeth, we are going to lose. So as beginners of implantology, if you have started implantology, you need to think in such a way that how can I preserve something so that when I come back after 4 months of extraction, I have sufficient bone volume to place the implant in the right ideal position. So this is one of the strategies: preserve, use, and reconstruct. Preserve, when you are doing yourself extraction, you have a treatment planning where you can preserve that bone as much as possible and use that bone what has been preserved to place the implant in the right position. And reconstruct, when you get patients from other practices where the extraction has been done already without the concept of preservation. So let us think and go further, starting from basic procedure. If you are a beginner of implantology, if you have not done many cases of grafting, I would suggest that one of the simplest grafting technique what you can do in your practice is a socket grafting technique. Because when you do a socket grafting, it doesn't mean everything is held there. That means all the bone what is existing on the day of extraction is going to be maintained when you come back and place implant 4 months later. It only means that even after shrinkage of some amount of bone, the bundle bone is going to go away, but you still have sufficient bone to get that implant in the right three-dimensional position. And at the same time, you might end up having sufficient thickness of the buccal plate to get away without any grafting procedures. So what is this socket grafting procedure? There have been various terminologies for this: socket grafting, socket preservation, ridge preservation. Now, to be very frank, you cannot call it as preservation because you're not preserving whole of socket. You are going to lose some amount of bone. You are going to have some horizontal collapse, that is buccolingual collapse, a minimal amount of vertical collapse, even when you are doing a socket grafting. Now, the biological rationale of socket grafting is you take out the teeth, clean the socket, remove the infection, put a graft into that socket, which is a resorbable graft, so that when you come back after 4 months, you have some amount of vital bone which is formed, and then you can place implant in the right 3D dimension without having to do a large augmentation technique. So that is the concept what we are focusing. We are going to have bone regeneration so that we have sufficient bone at the time of implant placement. So let us see some of the cases of socket grafting technique. Now there's a classic technique which is called a socket seal surgery, which has been published. So what is this socket seal surgery? So let us see this technique. So basically you can see there is a teeth which cannot be restored. So we need to extract this teeth. So when we extract teeth, when we are thinking of doing a grafting procedure or when we are thinking of doing an immediate implant, the extraction has to be as atraumatic as possible. So for atraumatic extraction, what do you mean by atraumatic extraction? Atraumatic extraction means that you need to be atraumatic to that buccal plate, which is very, very thin. As I told you, it varies between 0.5 to 1 millimeter. So if the thickness of the buccal plate is so thin, if you put force on the buccal plate, you're going to lose that bone. So atraumatic to the buccal bone, use instrument something called as periotome to luxate the teeth so that the teeth become mobile inside the socket, and without applying any kind of buccolingual forces with your forceps, you vertically pull it out. And once the teeth is out, the next important thing you need to do is curate the socket, remove all the granulation of the socket. Now, once you remove the granulation tissue, which is basically in the apical area, if there is resorption of the teeth, internal, external resorption, there might be in the middle third. So remove all those granulation tissue, which might cause inflammatory reaction when you put the graft. Okay, so remove that and then irrigate the socket thoroughly with the saline. Some of the people tend to irrigate because they see infection. They tend to irrigate with chlorhexidine or povidone iodine. You should not be doing it because there might be chances this can interfere with the bone regeneration. So the saline is the best way to irrigate the socket and disinfect the socket. Once you have a clean socket, you can graft the socket with the bone graft material. Now the choice of graft material, as I told, is a graft material which can resorb in a 4 to 6 months period. Around 50% of the graft should have a remodeling, so that when you come back, you have some vital bone, so that when your implant is going in, your implant is coming in contact with that vital bone, which will lead to osseointegration. So if you put any long resorption product like a xenograft, what will happen is you need to wait for longer duration of time before you place your implant, because your implant will not be in contact with vital bone. So ideally speaking, for me, if I'm doing a socket graft, I would like to go for a remodeling capacity of a graft material, which is between 4 to 6 months. So here the extracted teeth, then I have cleaned the socket and I have put a allograft material here in a putty form, which is in a putty form. And once the graft is placed, you just loosely pack it into the socket. And then what I do is, to hold that graft inside, I can go to the palate and take a very, very thin mucosal graft from the palate between the premolars, and I use a soft tissue punch to take out this graft, and the size of the punch should be just the size of the socket at the entrance. So once the punch is derived, I just take out the epithelium and I take around 0.5 of the connective tissue onto the epithelial graft, so that the bone is not exposed. It is just in the connective tissue layer. The patient will have least amount of morbidity by using this technique. But again, when you are taking out, you require to place some kind of protection to this area. Once the graft is taken, you shift it, put it in the entrance of the socket and suture it like this, so that you hold the graft in place. Now, there are easier techniques to do this other than the original socket seal idea. Now comes the temporization. Whenever you temporize, especially in the anterior zone, we tend to temporize it because of the aesthetic purpose. Now, temporization is a very important thing. Why it is important? You cannot go and give a removable temporary denture for the patient, because it will have a flange and it is going to compress the area where you have put graft, and there might be more resorption of bone. And also, when you are doing a temporary which is removable, whenever the patient removes and puts it back, there will be micromotion in the area of the flapping. and that might cause the micromotion of the graft, and it can cause fibrosis of the grafting material what you have placed. So ideally you use a S6 appliance to temporize it, or you can use a Maryland bridge to temporize it, so that you don't have any kind of forces on the augmented site. And come back after 5 months, you can see in this case, we have sufficiently held the buccolingual bone volume. 0.5 millimeter resorption still has taken place, but we are having sufficient bone to place our implant in the right 3D position, right? The other way of doing a seal of the socket is to use the collagen cones or collar tapes, which can be used. You get also mucograft socket sealing caps. You can get mucoderm tapes, which can also be used to hold this graft in place. So this is the way we do a straightforward socket grafting technique when all the walls of the socket are intact. Now, Senthil, do you have anything to interfere?
Yes, that's a great overview of the socket grafting. A couple of questions has come across. Tarun, how often do you do socket grafting, and how do you decide this is going to be socket grafting or not?
Okay, now if it is a beginner of implantology, the beginner will always be doing straightforward patient. That means he's not going to attempt an immediate implant, right? In such scenarios, he is going to graft all the sockets where he is going to place the implant after 4 or 5 months. And for an implantology is already doing immediate implant. Now the question comes whether to do an immediate implant or do a socket grafting. So that is the decision point where whether we can do an immediate implant. So whether we can get stability for immediate implant, is there any acute infection in place? So if there is no apical bone to get stability, then we will probably do implant placement after 4 months or 5 months. So in that case, what we do is we graft the socket, come back after 4 or 6 months and place the implant. So right. That is the decision making. If you are not doing immediate implant, you're going to do a delayed implant placement, I would advise that you graft the socket so that at least when you come back, you have sufficient bone.
Okay, that's great. Just one more other thing. This may be a bit controversial, but there is some studies showing that you curate the socket, clear the granulation tissue, but put the granulation tissue back into the socket and use the collagen membrane. And have you come across?
Yeah, I have seen that. But what happens is you are removing the granulation tissue from the apical end. Yeah. Usually you use this granulation tissue to cover the socket. Okay. Once you place the graft, you cover the socket. So what happens is you are taking out the granulation tissue, you are bringing it out from an anaerobic environment and making it outside the socket. Now you're bringing it into the aerobic environment. So all those anaerobic bacteria, microorganism, which is mainly anaerobic bacteria, is going to go away. So your basically granulation tissue is now converted into a tissue which can be a fresh granulation tissue base for the healing to take place. So you can do that if you have good solid granulation tissue which can come out of the socket, and you put it on the palatal side of the flap, socket flap, and then use it as a drape on the external surface.
Sure. Okay.
I also, Tarun, if I can just interrupt for another second. This is a very interesting question from Neetu. Hello, Neetu. What Neetu asks you is, you did show how you can punch and take a piece of epithelial tissue from the palatal aspect. You showed how you can determine the circumference of the punch. What she wants to know is, how are you going to determine the depth of the punch in terms of trying to extract it?
So what we are looking at is around 1 millimeter of tissue thickness. The graft is of 1 millimeter. So what we can take guidance is the bevel of the blade you use. Now the bevel of any of the blades, 15 or 15C blade, is around 0.75 millimeter. So use that for your guidance of depth, so that you don't go deeper than the bevel of the blade. So you know that your graft is around 1 millimeter. So that is how you can control the depth of what the graft you're taking.
I hope, Anita, that answers your question. Yeah, we can, I think, carry on with the rest of it. Thank you, Tarun.
Okay, now the next scenario is when your buccal plate is already lost. There might be because of various factors. It might be because of the spread of the infection. It can be because of resorption or external resorption of teeth. The buccal plate is already lost. So how do you graft when the buccal plate is missing? We have a technique which is given by Tarun, which is called as ice cream cone technique. So what you basically do is build that wall which is not there. So you make the membrane, you take a collagen membrane. This is a schematical diagram which is taken from Tarno's article. So you cut it in a shape of ice cream cone. So basically you have a narrow part of the membrane and a wide part of the membrane is toward the entrance of the socket. So you place this membrane onto the wall of the buccal plate of the socket so that this portion of the membrane becomes the wall for the bone graft to be held without this flap or the tissue invaginating into the socket area. And then you put the graft so that when you poke the graft, this membrane gets stabilized, and then you push this the wider portion into tuck it into the palatal flap and just put a small suture so that everything is stable inside. Okay, this is when you see a patient when your buccal plate is already lost. So you can see that flap is falling down. That means the buccal plate is completely gone. So we use a membrane, collagen membrane, shape it in the shape of ice cream cone. Basically, it is a narrow apical and a wide coronal portion, and put it into the socket. Use a graft, pack the graft into. Now you see that membrane is stable because of the wedging effect of the graft. And then you bend the membrane, tuck it into the palatal side, and then you can suture. Here I have put a platelet-rich fibrin plug so that my membrane is not exposed to the oral cavity. The platelet-rich fibrin plug is going to stay there around 15 days. In that meantime, epithelialization will complete on this fibrin matrix, so that membrane doesn't resorb fast when it is exposed to the oral cavity. So I will come back after 5 months of healing, and now you can see in the IOP I have good bone. These are the good old days when we didn't have CBCTs. And when we opened, we had very good bone formation, and we could place the implant in the right 3D position and restore it, right? So that is ice cream cone technique. Now the last stage of extraction socket management is when you don't have any bone, when there is large volume of bone loss, when you have a lot of buccal plate which is completely destroyed, your furcal bone is completely gone away, where you're going to do a large grafting procedure, you end up doing a guided bone regeneration in a socket. So here what you are doing is extracting the teeth, going through the same procedure of cleaning the socket and disinfecting the socket. And you can see here huge amount of bone is lost. Horizontally, vertically, you see a huge amount of bone which is lost. On the buccal side, you can see almost 8 mm of buccal plate is missing. And what we do here is once the cleaning is done, we are using a graft material which is fast resorbing, which is tricalcium, beta tricalcium phosphate. And this resorption around 4 months to 5 months time, you have complete resorption of the graft. And then you put a collagen membrane on top of it, and then I cover it with plate-rich fibrin membrane because we cannot completely close the flap because it is an extraction socket. So I use this PRF membrane as a matrix for healing to take place so that my collagen membrane is not exposed. Then come back again after 4 months of healing or 5 months of healing. I open the flap and you can see there is a beautiful bone formation. Whatever has been lost has been restored. And now is the time for placement of implant. I just take a Trifine and take that bone sample and send it for study in the histology to see what kind of bone has formed. And when I see that histology, I am the happiest man, you can see that there is complete turnover of that graft into a new bone formation. That means my implant is coming in contact with a bone which is completely vascular, which has osteocytes in it, which has osteoblast in it, which means it is going to integrate with the bone which is newly formed bone. It is not a graft material anymore there. Now comes to a point that you have managed the sockets, but you're going to place implant in somebody else's patient, or you have extracted, you're not grafted it, you come back, you see there is a collapse, which is there with there is a rich deficiency. Now you need to think how to graft it. So one of the simplest grafting procedure in implantology is guided bone regeneration. So we will see more about this. And we know that by now why we need to graft, because you extract teeth, you lose bone, and you don't have sufficient bone to place implant, or you have deficient bone to place implant. Like an example, as I showed, this is a socket which is extracted. You see how big the socket is, but when you come back, if you don't do anything to this socket, and I come back and see after 4 months of healing, you see that the ridge has shrunk. There's complete shrinkage of the ridge. So when I place implant, maybe one thread is exposed on the buccal, two threads are exposed in the buccal. So I have to do something, some grafting procedure. So that is where the GBR, or the guided bone regeneration technique, comes in. So for all these procedures, you need to do a hands-on course so that you learn that skill. All these things are, you need to have a flow of things in your practice. You first learn implant, then you learn to do small grafting procedures like socket grafting. Then you go, you go to the next stage of doing minor augmentation procedure, and then you go to the advanced augmentation. So there is a learning curve for everything. We need to first we'll learn it theoretically, and then we do hands-on, then we do hands-on on patient, and then we go and practice. Of course, we need to go from step by step. So we will know when to do by who, which of your skill levels. So why do you require bone grafting? Because we know that for implants to remain healthy, we now have literature to say that for our implant to be healthy long term, we need to have 2 to 4 millimeter of buccal bone and 2 to 3 millimeter of soft tissue thickness. And the soft tissue, at least 2 mm should be keratinized, not as alveolar mucosa which is covering your implant. For everything, we require this. We need to have it for long-term maintenance of the implant without having peri-implantitis. We need to have it for aesthetics so that our metallic hue is not seen. For everything, these are the criteria which needs to be followed. So when we talk about guided bone regeneration, what are the biomaterials we require? We require bone graft, we require membranes to cover this graft material, or titanium to cover this material. And then we require some fixation tools so that we hold everything stable. And then we require biological modifiers like growth factors, like your platelet-rich fibrin, like or your RHBDGF, BMPs. There are so many growth factors which is used today. So we'll discuss all of that as we go further. Now, when we talk about bone graft material, there is plethora of material which is available. There is autograft, which is xenograft. Then there is alloplast, allograft. And then there is biological components like enamel matrix proteins, platelet-derived growth factor, BMPs, PRF, etc., etc. Then there is modern alloplastic material like ribose-based cross-linked collagen material, which is coming up in the latest as a graft material. Then we have calcium phosphosilicate, which is a new generation alloplastic material. So which one to choose when is the question. For everybody, you need to see, oh, there are so many, I can use anything, anywhere? No, absolutely. You need to know when to use what. So that for that, you need to understand what type of defect you are handling. So this autogenous bone can come from various sources. It can come from symphysis, it can come from ramus, it can come from anterior palate, it can come from tuberosity. All the sources are there for your autogenous sources. But when you are doing a small GBR, if you tell your patient, I'm placing an implant in the maxillary anteriors, and I want to open your ramus, nobody agrees. They'll tell, why you want to do a second surgery? So we need to find out autogenous sources which is close to the surgical site, or you need to use graft material which will not lead to this kind of secondary sites. So gold standard of material is dependent on the characteristic of the material, whether it is an osteogenic graft, whether it is an osteoconductive graft or osteoinductive graft. Now, if you see the gold standard material, it is always autogenous bone because it has all these characteristics what is required. It has osteogenic because it has cells in it. It is osteoinductive because these cells has the growth factors in it. And it is osteoconductive, it will maintain the space till the new bone formation takes place. So if you see the literature and try to find out which is the best graft material I can use, you will come out again with the 1950 answer. It is autogenous gold bone, right? But it is not necessary that every time you go to the ramus or chin, probably we can use small instruments like the scrapers and autogenous chip makers, which can be used very next to the implant site to get some autogenous bone. You need that source of cells, you need that source of graft material. If you have 1 cc of this autogenous bone, it is sufficient. You don't have to go to ramus or chin. You can just go to the nasal spine, scrape a little bit of autogenous bone, whatever drill you are using, what comes out of that autogenous bone is sufficient to get that cells and the induction. If that is there, you can always increase the volume by using bottle graft or or a different type of xenograft and alloplastic material like beta TCP, you can use it. Now, autogenous bone, you can use it to leach out whatever good it has. What you need to do is scrape that bone and put it in a saline and leave that saline for some time when you are doing all the other things with your implant placement, membrane fixation. So what happens is this autogenous bone leaches out all the growth factor. They found out 43 growth factors in that saline leached out from the bone, autogenous bone. So then use this saline which is leached out growth factor to mix with your any graft material. Your material becomes magic. Your material becomes a bioactive material which has all the growth factor, and regeneration is very, very fast with this. So use your common sense to apply the good of autogenous with minimal amount and enhance the volume by using bottled graft. So what are the graft properties we are looking at? We need osteoconductivity, which is most important. Now, autogenous, if you're getting it with the scraper, it doesn't have osteoconductivity. It has a property of osteoconductivity only if it is a block. And in GBR, we are not using block. So what if somebody takes out only scraped autogenous bone and puts it and put a membrane, he's not going to get sufficient bone because space maintenance is not there. So you need to choose your graft, mix your graft so that you get good of both the things. So if you see, autograft has everything because of which it is called as a gold standard. But if you see other graft material, allograft, xenograft, and alloplast, they have osteoconductivity. They maintain space for sufficient duration for the bone to heal. Now, bone has the ability to heal by itself. You just have to time that space, and time is to be given for that regeneration to take place. If you give time and space, the bone will heal. So all this graft is providing is space maintenance and scaffolding so that bone will heal by itself. So what is the particle size you will choose? There are many particle size in the bottle which comes in. So you need to choose the right particle size for a right procedure. So if somebody sells you a cheaper graft, probably the particle size is very less, like 0.5 less than 0.5 micron. Basically, it is a bone dust. It doesn't have scaffolding. It will crumple. There is no spacing between the particle for the vascularity to grow in. So what is the choice of material for particle size? 0.5 to 1 mm is the ideal particle size what we use for GBR procedure. Probably in a lateral sinus, we might use a larger particle like 1 to 2 mm. Otherwise, most often in dental implant practice, we use 0.5 to 1 mm particle size. Now coming to different type of defects, you have one wall defect to four wall defects. So depending on the regenerative potential of the site, you know how fast and how easy to regenerate that bone. If you see the top picture, it is a cyst ejaculated site. Now that is a four wall defect. It is like a cup. You put any graft in that, it is contained there. It has so many walls of the bone to give the vascularity, the cells to come into the grafted site, and the graft is in a container. So there is no micromotion. So beautifully it will heal, no problem. It is easiest place where you can start practicing your grafting. But if you see the picture down here, where the implant is placed, the implant is way far away outside the bony envelope. That means the bone has to grow all the way from here and go out down here. Now that is difficult area. There you need something, a different procedure to do a GBR to enhance the bone formation. So for an example, four wall defect means like a socket. You have the socket, all the bone walls are intact. So you put a graft, it is all contained. Only thing outside you have to put something so that the graft doesn't come out. Whereas a two wall defect is a much complex defect, difficult to handle. Now coming to the membranes, what we use for covering this graft material. Why do we use a membrane? So that these particles of graft doesn't go here and there. Otherwise they will do a dancing of Michael Jackson. You put a graft and some people close flap on top of it. It doesn't stay because the flap is going to move, and along with the flap, the particle is going to do the dance. So to hold it together, you have to put a membrane, and that membrane has to hold that for sufficient duration of time. So that is when you choose a membrane. What type of membrane do you want? So depending on the regenerative potential of the site, how much time it takes for the regeneration, you choose a membrane, whether it is non-resorbable or resorbable. So non-resorbable membranes are gold standard membranes because we started doing GTR way back in 1980s. We used only PT non-resorbable membranes. Then we saw complications with that. So industry slowly evolved into making membranes which is resorbable so that we don't have complications. So now we more often try to use resorbable membranes than using non-resorbable membranes. But at the same time, you have a particular scenario where you might require to use this membrane only, where there's a PTFE, which is a non-resorbable membrane, or a titanium mesh. But most often, as we move forward into the future, we might have resorbable membrane which can be controlled to the extent of resorption. How much resorption has to happen, that can be controlled. With the new biotechnology, we can control it. We need 9 months, we will get a membrane which can stay for 9 months. So research is on. So modern research will bring us resorbable tissues which will hold the space for sufficient duration of time. So in the resorbable, what is most commonly used? Collagen. Collagen is the most common membrane. What is the next common membrane we use? Pericardium. These are the most commonly used. Along with that, there are some synthetic membranes what can be done. That is calcium sulfate. Calcium sulfate. Now, calcium sulfate is a completely resorbable and you can mix it with the graft material. You can mix it with the graft and now you don't have to layer it with anything. You mix the graft and place it. The calcium sulfate sets and it holds that space, right? So you have a material in the United Kingdom. I think it's called as ethos. That is a graft which is basically beta tricalcium phosphate, which is having calcium sulfate. So when you mix it, it becomes something like a membrane along with a graft material, so that you don't have to use a membrane on top of it. But these have a particular indication where you can use it. Okay, that is about the different types of membrane. Now, Senthil and Kaushik, if you have something to ask, you can ask any questions which has come to you till this time.
That is a great brief overview of the grafting materials as well as the membrane. We have a question here from Jens. Hi, Jens. He's asking, is there any difference in material or technique choice based on whether it's maxillary or mandibular arch?
In the mandibular, we need to have a membrane which is more rigid because you are operating in areas where you have more musculature. Whenever you open a muscle and close it back, you are going to have contraction. So if a membrane is a very pliable membrane, it is going to compress that area and it is going to compress the graft. So ideally choosing, it might be a membrane which is more rigid in the mandible, and in maxilla anything works.
Right, okay. So do you use more of PTFE with reinforced PTFE in the mandible?
Yeah, you have to use a reinforced PTFE or a titanium mesh, or if not titanium mesh or PTFE, you create tenting screws or tenting screws so that there is no activity of the flap. That is, a muscle contraction is not going to affect the collapse of that membrane. So use some screws so that the flap is held away, and screw is rigid, it cannot be compressed. So you can do that.
Perfect. Hope that answers the questions for Jens. Yeah, you can carry on.
So now coming to the horizontal defect, depending on the buccolingual bone width, what procedure you will choose. So you need a decision-making tree. So this is a decision-making tree which has been published by Homle Wang, where you can see if it is more than 3.5 millimeter buccolingual width, you can do a GBR procedure. If it is less than 3.5, you can do a block graft. If it is 4 to 5 millimeter, which is like a borderline case, you can do a ridge split or an expansion procedure. Okay. Now, depending on primary stability you get or not, you can choose to do a simultaneous bone grafting, or you can do a staged grafting procedure where you just do a GBR and then come back and place implant. Okay. Now, let's see what is the advantages and disadvantages of this. Now, if you see this, an autogenous block, if you place, it will heal in 4 months, and then you place an implant in that autogenous block healed site, and you can restore it almost immediately or in the next 2 months. Whereas when you do a GBR in a staged approach, you need to wait for 9 months before you place an implant, because The bone what is formed is faster, but at the same it is not very hard. It is a mushy type of bone. So you need to wait for 9 months if you want to place implant in a decent, good quality bone. And then you wait for 3 months for that implant to get integrated, and then only you can do the final restoration. So basically, your time for final restoration is increased when you are doing staged GBR approach. So personally, when I do it, if I'm doing a horizontal augmentation, if I require, if I can do it simultaneously, place the implant and do a GBR, I go with GBR. If I don't think I can get primary stability, the bone is very thin, I would go for a block graft and then wait for 4 months and place an implant. A block graft can be autogenous, it can be allogenic. Today we can use allogenic bone block, and almost in the similar speed you can heal that bone using growth factors. Okay, you can inject RHPDGF into this allogenic block into the cancellous sections, and you can get a very fast healing, and in 4 months your bone is ready to place an implant. Now let's classify the defects, what type of defects you are dealing with. A defect can be horizontal, that is a buccolingual defect, that is the width of the bone is not sufficient. It can be a vertical defect because the height of the bone is not sufficient. Whenever there is a vertical defect, most often it is a combined defect, which is a combination of horizontal and vertical defect. So you have a deficiency buccolingually as well as in the height of the bone. So when you see a CPCT, when you see the bone, you're going to think about this, whether it is a horizontal defect, whether it is a vertical defect, whether it is a combined defect. Once you classify this in your mind, you know what is the next treatment plan, what you're going to do, what is the graft material you're going to choose, what is the procedure you are going to choose. Now, depending on that augmentation factors, what kind of defect it is, you need to classify whether it is a straightforward regenerative case or it is a complex regenerative case. So because everybody cannot do all the grafting procedure. So if it is a ultra complex case, even I would refer it to somebody who has the skills to develop both, right? So you need to know what is your skill level and classify the defect so that you know whether I can handle it or I can refer it to somebody who can do this procedure. So if you see, for an example, an horizontal defect can be straightforward also, it can be advanced also, it can be complex also. Why? Because it depends on the augmentation needs and the augmentation defect relation to the outside the contour or inside the contour defect. Okay. So if it is a horizontal defect, which is a low augmentation need, it is a straightforward case. If it is a horizontal defect with an inside the contour defect, it is a straightforward case. So depending on what type of defect it is, you need to understand whether you can do it or refer it. And at the same time, I would tell that everybody has a learning curve. Everybody can learn slowly and achieve the skills by doing various courses. What you do is you achieve the skills to do all this procedure. As you go further in implantology, you will learn how to do advanced procedure and complex procedures. Now let us see what are the different types of defects when an implant is placed. What kind of defect is created? So basically it can be a fenestration defect or a dehiscence defect. Now this fenestration defect is called fenestration because the marginal bone is intact here and the apical bone where the implant's apex is there is intact. So only in between there are few threads which is exposed, and that is called as a fenestration defect. Now these fenestration defect can be class 1 or internal to the defect or external to the defect. You divide it into class 1 and class 2. So if the implant is within the contour, if you see a cup-like defect and the implant is below there down, it is a internal defect. That means you have a contained defect. In the contained defect, you put a graft, it is stable. The bony walls to supply the vessels and the cells is higher, so the regeneration is easier. So type 1 fenestration is easier to treat, and type 2 fenestration, where the implant is sticking outside the bony envelope, it is difficult to treat because the bone has to grow all the way from down and cover it. So your graft material has to have more regenerative potential, the membrane has to stay longer, and you might have to use more rigid membrane. Now dehiscence, what is this dehiscence? When you don't have that marginal bone on at all, like your fenestration had marginal bone, here you don't have a marginal bone. You are exposed from the flat form of the implant till the apical portion of the implant which is going into the bone. So this is daisy. So there is no bone in the crestal portion. So it can be again class 1, class 2. What is class 1, class 2? Internal to the defect or external to the defect? If you see this defect here, the implant is way below the adjacent peak. So that means all these walls are going to supply the vessels into this region, and it is the graft is contained in this defect. So the healing will take place in easily. So in this case, if you use a graft material, I will just use ethos paste there. It will work fantastic. It will heal with good bone formation. But I cannot use the same graft and same membrane here. I need to have a membrane which is rigid, which will hold the space. And I need to use at least some amount of autogenous bone to create that area to heal faster. Now, just to show an example, what is external, internal. If you see this implant is outside, whereas the bone is way down below. So this is an external defect. If you see this, there are both external and internal defect. In the coronal portion, if you see, the bone is higher, whereas the implant is lower. So it is an internal defect. Whereas you go out of the apical portion, you see that the implant is outside, whereas the bone is down below. So this means your implant is a type 2 defect. So you can see here, various types of defects are there. You encounter all these different type of defects. So when you encounter, you need to understand what type of defect it is, so that you know what kind of procedure you are going to do, and can you do it, or you want to refer it. Now, if you see this simple defect, which is all internal, there is bone everywhere, you just put any graft, just a simple collagen membrane on top, it will heal beautifully. Same thing with this, it is all inside. Just the labial plate is missing. So you just inject some graft here, it will heal, right? Whereas here it is different case. Here the bone is thin, it is external. So you require something to hold the space for good bone formation to take place. Again, an external defect. If you see this, implant is far away. You can see this blue line, the implant is far away from the bone. That means the bone has to go all the way from here, grow all the way here and come back. And not only that, it is not just about covering. You need 2 to 3 millimeter buckle to that implant again. So you need to have that kind of regenerative capacity for your graft, space maintenance, and a membrane which will hold the space for sufficient duration of time. Now let us see some of the guided bone regeneration technique. There are various types of guided bone regeneration. You can see collagen membrane, titanium plate assisted, or PTFE membrane assisted GPR procedure. So one of the principles what we use for guided bone regeneration is called as PASS principle, again Homle-Wang's principle, where P stands for primary wound coverage, which is tension free. So whenever you do a GPR procedure, one of the key element in your flap management is tension-free closure. How to achieve it, we will see in some of the slides in the future. The next is A, which is angiogenesis. Make sure the site receives sufficient vascularity so that you decorticate if required, if you want the marrow spaces to have some vascularity to develop. And the double S stands for space maintenance and stability of the wound. So as I told, space maintenance is given by your graft material and the membrane what you cover it up with. And the stability of the wound is given by how well your membrane is held in place, so that you use some tacks or screws to hold that membrane so that it doesn't shift. And your implants. So basically, once the graft is placed, your graft, the implant, and the membrane, nothing should be moving. The moment one of these moves, you might end up having a fibrosis of the tissue. Now let us discuss some of the flap designs for GBR. What are the different flap design you have? What is the aim of your flap design? You basically design your flap such that you get a tension-free closure without having any scars, without recession of adjacent teeth, and you don't have loss of papilla.
Sorry, Tarun, can I interrupt you for a minute?
Yeah.
Yeah, so we got a couple more questions in terms of grafting and membranes. I thought I'll just ask you, this may be the right moment to ask.
Yeah, please go
Jitin,
ahead, Sanjay.
Jitin is asking, is it true that resorbable membrane should not be exposed to the oral environment, and thus there has to be a primary closure in case of socket preservation if using a resorbable collagen membrane, i.e. post-extraction socket grafting?
Yes, perfect. If you are using a collagen membrane to cover the socket, you need to cover that collagen membrane with something. So if you see one of the cases what I showed, I use a PRF plug on top of that collagen membrane so that it is not exposed to the saliva. And this PRF plug is going to stay for 15 to 20 days. And this fibrin gets converted into an epithelium. So basically my collagen is not exposed to the oral cavity. And
Okay.
that is why primary closure is mandatory. But in a socket, you don't try to achieve a primary closure, because when you try to achieve a primary closure by giving a vertical incision, you completely change the dimension of the mucogingival complex. So you're going to bring that attached gingiva palatally, and when you come back to place your implant, you don't have keratinous tissue around your implant. So in the socket, we try not to do a coronally repositioning.
Right. And the follow-up with that, there's a question from Rashid. Is in socket grafting, do you use only autogenous or mixed xenograft material?
If I am using a xenograft in a socket, which I rarely do, I mix it with at least 50% of autogenous scrapings. But again, it is a procedure where I have never reflected a flap. So going and getting an autogenous is a big thing. So I have to open other side to get autogenous. So my choice of material, if I am putting xenograft, I place in only xenograft into the socket when I have to wait at least 2 years time. For example, if I am having an owl's teeth in a child who is 14 years, and I know that at that point of time I cannot place implant in that child. So what I'm going to do is I'm putting xenograft there because I know that it is going to resolve very slowly. So when the child becomes 20 years old, when I come back, I still have sufficient bone, but I would have had this conversion of this xenograft into some vital bone. So my material of choice would be something which resorbs a little faster, like an allograft or an alloplast, which is like 5 to 6 months resorption period. So that is how I choose my graft material.
Right, right. And there's one more question from Ajay. What is unwanted cells exclusion in the S of pass principle?
Yeah, when you, as I told you, that we are putting a membrane so that only the bone cells can grow into that grafted site. So when you cover with the flap, if the epithelium is there, the epithelium from the flap, which is the fastest growing cell in the oral cavity. So epithelium forms the fastest, next is fibroblast, and then the osteoblast. That means osteoblast is the laziest cell of all. So if you
Okay,
don't cover it with the membrane, the other cells will occupy that space. So that is why we cover it with the membrane, so that we exclude this fibroblast and epithelium to enter into that grafted site. So
right.
that is the reason why we exclude those cells, space maintenance by excluding cells.
Okay. Just one more thing on that, follow up on that. You did mention that the key for the success is based on the no movement of
Yeah.
the graft when it's healing. What is the critical period, Tarun?
The critical period is still the osseous, once the framework of the osseous structure forms. So that is around 4 to 6 weeks.
Four to
4 to 6
6 weeks.
weeks.
Okay,
Now,
brilliant.
even it depends on the region. As I was telling, in the mandible, you have more contraction of the muscles. There is more
Right,
compression. This bone, what forms in the initial stages, is a soft bone. It can be still compressed. So when in the maxilla, it is not much of a muscle activity. So in the maxilla, it is okay. 4 to 6 weeks, your membrane resorbs, it's fine. But in the mandible, if it happens, you have an osseous structure, but because of the muscle compression, your bone can start resorbing.
perfect. Yep, that's it for now. You can carry on.
Okay, now
Thank you.
depending on the different techniques of incision, you can see here we are doing a papilla sparing incision. What is this papilla sparing incision? We just don't touch the adjacent teeth papilla. When do we do this? When we have an interdental bone height, that is the bone height of this teeth is less. That means from the contact point to the interdental bone height is less, it's greater than 5 mm. Then we do an incision which spares the papilla, because if there is bone resorption in the beginning, if you open the papilla, there will be shrinkage of the papilla and leading to black triangle, which is not at all good in the aesthetic area. So we do a papilla sparing incision in the cases where there is no good interdental bone. Now, in otherwise, if you have a good interdental bone, as you see, the peaks of interdental bone is good. So we can go ahead and reflect the papilla, and we usually give a vertical incision, one teeth away from the site where you are going to graft, so that we have sufficiently large flap, and we can give a nice wide base. And when you see a vertical incision, you can see here there is a nice wide base incision, and we need to include the papilla completely of this area, or we can disclude. As you can see in this particular case, I have not elevated the papilla of the adjacent teeth. So either you completely include the papilla by giving an incision from here, or you disclude the papilla completely. Other way of doing incision is giving an incision without involving the adjacent teeth. So when do you do that? When you do a large augmentation procedure, and you know that you're going to coronally reposition the flap to a large extent. If you include the adjacent teeth, the mucogingival component of the adjacent teeth also gets compromised. You may not have keratinized gingiva on the adjacent teeth also, because you are moving it so much. And when you are moving it so much, your flap will come onto the enamel surface of the adjacent teeth. So in such scenarios, you give the incision very next to the defect area. Other way of doing is when you have a high smile and patient, you don't want any scarring to be seen from the vertical incision, is you push that vertical incision behind the canine, distal to the canine, and extend the horizontal incision as long as possible, so that you have a large flap without vertical incision in the anterior sectant, so that you don't have a vertical incision scarring. This is a simple technique what we do every day, no vertical incision, just a circular incision on the adjacent mid-crestal incision and a full thickness elevation, which we do on a regular basis. When you have a small augmentation like a contour augmentation, you just have to do a regular incision technique. Now, the most important incision is a periosteal release, so that you can get passive closure. So how to do that? You can see in this particular video, just with the bevel of the blade. Again, the bevel of the blade is around 0.75. I don't go beyond that when I'm giving a periosteal release. So periosteal release will remove the rigid periosteum from the flap. You enter into the area where there is elastin fibers. So when you have elastin fibers, you can expand the flap. When you expand the flap, your flap becomes more mobile and more elastic, so that you can have passive closure without any tension when you are suturing. So you can see that just with the bevel of the blade, I am going in and going into the connective tissue base and separating the periosteum. Once that is done, the incision is done. I am not going to again and again giving incision there. So when I give that incision, it is just 0.5 to 0.75 mm deep into the periosteum. And then I take a blunt instrument, and then I use that elastin fibers to be stretched. Just stretch that elastin fibers. Okay, now you can see that elastin fiber is getting stretched, the flap is getting elongated. Now when I put it back, my flap is longer, so automatically I can suture it without having any tension. So it is a passive, tension-free closure. And you can see I can bring it to the incisive level. That means it is like 10 millimeter. I am going to have more pullover of the flap. So you can see the stretchability of the flap after doing the periosteal release. Now let us see some cases. Early implant placement with classic GBR. What is early implant placement? You extract the teeth, wait for 8 weeks for the soft tissue to close the socket, come back, open the flap. Now the soft tissue is intact. Now you have a defect, which is an extraction defect. Whatever resorption has to take place on the buccal plate is resorbed. But you're going to place an implant just like your extraction socket, because you don't have bone fill in the extraction socket at 8 weeks. So here you can see soft tissue is completely healed. This is a 10 weeks old socket case after extraction. And you can see the socket now is filled with soft tissue. So I elevate the flap, take out all the soft tissue from the socket and put it onto the labial side, so that I simultaneously increase the thickness of the buccal flap, because I am including that soft tissue which is in the socket into the buccal side. It will act like a connective tissue graft being done. So once I do that, I clean all the soft tissue from the socket, place the implant by drilling into the right place. Okay, you can see the implant goes in here, and the defect what is formed is a classic defect, which is an internal defect, which is a contained defect because you are putting in a socket. And now what you do, just take some autogenous from the nasal spine. If you see the earlier picture, I have exposed the nasal spine here. I will scrape autogenous bone. I will show it in one of the videos. And you can see I place the implant in the right 3D position. Then I put a collagen membrane on this side. You can see I have put 2 tags so that I make the collagen stable. Then I take autogenous bone. On the surface of exposed implant, I have packed the autogenous bone. And then I have put some autogenous bone, which is just from the nasal spine, not from secondary site, just from nasal spine. And mix the autogenous with alloplastic material. It can be a no-bone dental morsels. It can be a beta tricalcium phosphate. I mix it with that and then place the membrane on top of the graft and suture. Now, when I am suturing, the most important thing is it is a dual layered closure. What is this dual layered closure? Dual layered closure means you are putting 2 types of sutures. So the first suture, what you give is around 5 to 8 millimeter from the incision line. This is the incision line. So I take around 5 to 8 millimeter above and do a horizontal mattress suture at this level. So when I put a horizontal mattress suture at this level, the flap doesn't have any tension at the margins. So when I tighten it here, I'm not going to reduce vascularity at this side. So my necrosis of the margins of the flap is very minimal if I'm doing like this. So I remove all the pressure which is on the flap by putting this suture. That is a horizontal mattress suture high up on the flap. And then I give interrupted suture so that it is very easy to give interrupted once you give this because it will just close together because the tension is already removed by doing the horizontal mattress suture. And then you put interrupted suture or a double sling suture. Come back after 4 months without minimally invasive, without reflecting much of flap. We do place a healing cap, and after a few days we take do a temporization so that we get a right emergence profile like this. And once the emergence is created, we take a customized impression of that site with the soft tissue in the impression, and then do the final restoration. So it is a simple, straightforward GBR case. This is something which you get into the second line of practice. First, you do socket graft. The second thing you do is early implant placement with a straightforward GBR case. So this is how it looks. Happy patient. Yeah.
While you're speaking about the external defect of a single tooth replacement, there's a question from Divya. Hello, Divya. So she's asking you to enlist types of grafting techniques which are successful in external defects where implants lie outside the alveolus. So very similar to what it is. So what are the different techniques you think would be useful?
So when it is an external defect, number one, you need to have autogenous component of your grafting. That means at least 50% of your graft particles should be autogenous. Second thing is coming to the membrane. What type of membrane you will use? You need to have a rigid membrane. So either use a titanium mesh. If you are using a new generation collagen membrane, which stays for longer duration, then what you do is use tenting screw so that you create that spacing so that it doesn't collapse the collagen membrane, and then use the membrane on top of it and suture. Or you use a non-resorbable membrane like a titanium mesh or a PTFE, titanium reinforced PTFE, so that it holds the space till the time you remove this. A collagen membrane, the problem is resorption time is not controlled. Of course, the new generation collagen membranes are coming up, which can be controlled for longer duration. But you still have something called as muscle tension. So to avoid that muscle tension, either you put a titanium screws as tenting devices and then use collagen membranes, or you go for titanium meshes, or you use a PTFE membranes. So that is what you have to follow when we are doing for a pure external defect where the implant is lying outside the contour of the contour of the bone. I hope the question is answered.
Yeah, I hope so. Yeah. So you can carry on with the next one now.
Yeah. Now we will see a technique which is recently developed, which is something called a sausage technique. by Istvan Urban, where he basically uses an elastic collagen membrane so that it can be stretched over the graft, and a taut membrane is created so that the graft particle is like, held in a sausage. So basically a sausage is putting the meat inside and, packing it so that it is all tensed inside. So same thing, we do it with the collagen membrane. Here you can see a large dehiscence defect, and basically it is a combination of external and internal defect. On one side it is external, one side, other side it is inside the defect. So what we do is autogenous bone. Where do you take autogenous bone from? Basically we take autogenous bone right here on the apical area using an autogenous chip maker Trifine. So what is the technique we use? Sandwich bone augmentation technique. So sandwich bone augmentation technique means you use autogenous on the surface of the implant, and on top of that we can use your bottled graft which is mixed with autogenous, and then you have a membrane. The green color, what you see is a membrane, and then close it. So basically that same thing we do. We take autogenous from the same surgical site. This is the autogenous chip maker. And what comes with autogenous, that 50%, I just layer it on the implant surface. So my implant surface is basically covered with pure autogenous so that there is no contact with xenograft, which is non-resorbable. And then I mix it with autogenous bone, xenograft, and a liquid of PRF, which is basically a liquid which is made from PRF, which makes it all into a jelly conditioned medium. So that I will use it on top of that autogenous, which is like a layer, and that provides a space making. Now you can see this is great, creating space making efficiency of the graft material. And then I put my collagen membrane to be stabilized either sutures or using tacks. So here I am showing both the things were done. So I have tacked it, stretched the membrane and tacked it in all the sides. And I have put sutures to hold the membrane back down so that the center part, the grafted part, is like a sausage which is taut and holding everything down so that it doesn't have any micromotion, and the graft is held inside without having any micromotion. And then we, with the same choice of suturing, that means when you are doing a suturing, always do a suturing with dual, one apical mattress suture and at the margins just interrupted, or a sling suture. And then come back after 4 months or 5 months of healing, just do a minimally invasive to take out the tissue, put a healing cap, do a temporization, and go here till the final restoration is done. And you can see we have achieved the same level of as adjacent teeth when it comes to soft tissue after 1 year of, we so don't see much of resorption. A classic example, what happens to extraction and then don't do anything and come back after 4 months to place implant. So let's see, we extracted atraumatically, no flap was open. We didn't destroy the buccal plate, everything was intact. So what we did, just put a PRF plug and didn't put any graft, came back after 4 months, and you can see what has happened. You can see that nice big resorption, a U-shaped defect, right? We open the flap, you can see that. Where is the bone on the adjacent teeth? Here. Where is the bone for implant placement? Here. So you can see that this complete bone resorption. Why it happened? Why it happened? Because this belongs to that category of patient which is less than 1 millimeter. You can see that bone here, it is less than 1 millimeter. That means the bone has completely resorbed. So ideally, if you're not doing anything to the socket, if you're not placing an immediate implant and doing a grafting at that time, you put graft into the socket and wait for 4 to 5 months. And then when you come back, you will at least not be in this situation. You will have at least bone till here. So you can place an implant without much of a deal. So we have just around 1 millimeter crustally, but as we go apically, we have around here 2 millimeter down, 3 millimeters. So we can place our implant. We went ahead, placed the implant, and you can see there is a vertical component, which is a small vertical component, around 1 millimeter vertical defect. So what I thought was we will not use a titanium mesh in this case because it is an internal defect. We just have 1 millimeter of vertical defect. Let's try doing with a long-term collagen membrane. So we went with a collagen membrane which stays for long term. This is a collagen membrane from which is called as Krios. And it has a very good elasticity, very thick membrane. And I put autogenous bone, as I told you, on the implant surface. Then comes a combination of xenograft, autogenous bone, and IPRF, which is a liquid of PRF. And then I place that everything on top and then I pull the collagen membrane, drape it and tighten it on the palatal side, stabilize it like a sausage inside, and I put a pair of membrane on top of it, dual layer closure, come back after 6 months of wait and open the site. I've got regeneration completely. What was it? 1 millimeter vertical. I removed it. The bone is completely formed. I had no bone on the buccal side, completely formed. So bone can be regenerated if it is a minimal vertical, if you use collagen membrane, which can be long term, and stabilize it properly, and use the right combination of graft, probably you can do it. And in the second stage, what we did was to enhance the soft tissue bulk. We went to the tuberosity, took a small piece of tuberosity connective tissue graft using a soft tissue punch, de-epithelize that tissue, remove the epithelium part of this, and then place it on the buccal pouch, on the buccal side, so that you enhance the soft tissue volume in the anterior region. And this is how it looks after a temporization. And you can see nice soft tissue, nice contour, which has come back.
So
Any questions, Kaushik?
Yeah, if I am just gonna tell all the viewers today, Tarun is concentrating more on the basic principles of implant placement, soft tissue management, and bone regeneration. However, some of us who have started afresh are a bit puzzled about what kind of flap design we need to sort of use in what kind of cases, what kind of suturing technique we need to use in what kind of cases. Because Tarun is covering such a vast amount of subject today, it will be too much of a time. And so we have a very specific webinar exactly to explain about flap design and different suturing technique with every basic detail about those things. The webinar is coming on Thursday, if I'm right. So you can check on the website at dentalroutes.org. If you attend that webinar, that will give you a very detailed explanation. It's handled by Dr. Darshan Boindala. He is a duly qualified medical doctor plus a dentist who's very, very much into oral surgery. So he'll be explaining all of that in very much detail. So thank you guys for that. And going further, it is getting amazingly interesting now. So yeah, Tarun, if you can carry on with your next part of the lecture, please. Thank you.
Yeah, now let us see something called as contour augmentation. That means you place the implant, the bone is covering the implant. But we now know that we need to have at least 2 millimeters on the buccal side. If you have that less than 1 millimeter buccal bone on the implant, it is not going to stay. Why it is not going to stay? Because your implant is avascular and that 1 millimeter bone requires vascularity. So the vascularity is cut off for that 1 millimeter on the buccal side, and it will resolve. So you need at least 1.8 mm of buccal bone if it has to establish its own vascularity. If the bone has to have its own vascularity to preserve it, it's just to be 1.8 millimeter. That is a magic number. So we cannot tell you need to 1.8. I say always 2 millimeter or plus. So you need to augment even if the bone is less than 1 millimeter or 1.8 mm. If it is seen that you take a probe and see, okay, I have a bone which is less than 2 millimeter, I'm going to do a contour augmentation or cover it up. So here you can see the CBCT, you have that around 2.8 millimeter of bone there. Now we have some drills, which is amazing, which is called as denser drills, which expands the bone, especially the cancellous bone, which is a maxillary bone. And here what I'm doing is I'm using that drills and expanding that bone from 2.8 to place a 3.5 mm implant, and without having any exposure of the implant. So you can see here, we have just around 2.8 millimeter bone. I am going ahead and you can see the defect, what kind of huge defect it is. And I am going to place implant. And after placing implant, I still have that bone on the buccal side. But that bone is not sufficient. That bone is just around 1 millimeter. And that is going to resolve if I don't do anything about it now. So what I'm going to do is I'm going to build the bone to this level, the adjacent teeth level, so that I don't have any shadow when I put my restoration. So it is about aesthetics. We need to think when the patient has, young patient, aesthetic needs are high. When the patient's smile is high smile line, you need to think about aesthetics. You need to provide the best aesthetic to the patient. For that, you cannot just have 1 mm bone or 1.5 mm bone. You need to have bone which is according to the adjacent teeth. So you can see in this video, I just want to show this video, how do you collect autogenous bone? I don't go to any other side. Just open the nasal spine and just scrape from the nasal spine. I get very good amount of autogenous bone. Okay, I get all the autogenous from the same source. Okay, now I put it in the put it on the bowl with some saline that to create the bone condition medium, and then I do the periosteal release and all the things. And at the same time, I use my membrane. I tack the membrane. These are called as tacks. What going in there, you just like a nail it, tap it in, and the membrane is held in place with the tacks. So here you can see the membrane and step by step how it is done. The membrane is first initially stabilized, then you put the graft, then you stretch the membrane over the graft and put multiple tacks. Now the whole thing is very stable. Then you close the flap with passive closure and come back, do the healing cap and then temporization, emergence profile, and then you can give this kind of aesthetics to the patient. So let's see a defect which is difficult to treat, external defect, which is a difficult defect, a mandibular defect. Mandibular is a bone which you need to think because there is muscles there. There is muscle activity. There is contraction when you open the flap with the muscle. When you put it back, it is when it heals, it creates contraction. You can see here it is just 1 mm bone. And apically there is good bone. So I place my implant, there is a defect. In the mandible, as you see, I am caused small holes here. What is this? Decortication. Why do I require decortication? Because I need vessels, angiogenesis of pars principal. I created this so that the marrow spaces are open, and then I take out autogenous bone, bone condition medium. As I explained, first surface on the implant is autogenous bone. Then it is a mixture of alloplastic or a xenograft with autogenous, and then titanium mesh. If you see this, this is a mesh which is held in place. I'm using the cover screw of the implant to stabilize the mesh, and one more apically I put a screw or a tack on the mesh so that everything is stable. And then put some collagen tape or PRF on top of the mesh and close it, and come back after 5 months, open it and take out the mesh. You can see beautiful bone formation, which is more than 2 millimeters. And you can see the post-operative CBCT. You can see the CBCT, you can see the pre-operative here so thin, whereas here we have a 5 mm implant. And 5 mm implant on the buccal side, we have more than 2 mm bone. So that is the advantage. Even in external defect, where there was 1 mm bone, we placed a 5 mm implant, it was external to the bone, and because of the mesh and choice of graft, you can regenerate bone. Now let us see what we do for minimally invasive procedure when we are especially handling this contour augmentation. Today we do a lot of flapless guided surgeries. When we do flapless guided surgeries, we don't want to reflect a big flap and do a grafting just for contour augmentation. So we do something called a tunneling technique. So what is this? So if you see this, this is just around 1 millimeter bone is there on the buccal side of the implant when I plan. So what I do is I don't want to reflect a flap. I want to do it flapless. So I go ahead, make a small incision just in the vestibule of anterior to the canine. This is the area of my implant placement, and then do a full thickness tunnel with the tunneling instrument, which is a full thickness tunnel. And then I go and place my implant with flapless technique using the soft tissue punch and the guided surgery kits. So I have done a flapless implant placement here in the right 3D position as per the plan I did. And then I took the graft, I put the membrane inside the tunnel and hold the flap and the membrane together and start packing the graft into the site. And through that tunnel, which is almost like 3 mm length, and just use your graft carrier and inject it inside and pack it and just give one suture to hold everything in place. This is how it looks. Post-operative, you have build the bone, which is like 4 millimeter thick on the buccal side. Wait for the healing. It is a single stage procedure. I wait for 4 months, come back, check my ASQ value. If it is good, I go for restoration. And after 6 months of healing, you can see the bone has completely consolidated, and now I have a good 3 millimeter bone on the buccal side. Kaushik, do you have any questions to ask at this point, or should I continue?
with the tunneling technique that you are speaking about, Tarun, is that something that people should be trying at the initial stages, or they should start to get a bit more sort of apt with doing the open flap techniques before they get into this?
Yeah, of course, Kaushik. It is like, as I told, the presentation is devised in such a way that it is for the beginner, and then you go to the socket grafting, then you do simple, straightforward GBS, and then you do GBR, proper GBR with flap management. And then you enter into doing this kind of advanced stuff where you have control over your instruments. Tunneling is something you need to have total control over your instrument. Otherwise, your flap will be, in pieces. So you have to develop your skill gradually by doing various CPDs, and then going and doing hands-on, and then developing your clinical skills, and then moving from one stage to the second stage and the last stage. Now the few cases, what I'm going to do is going to
So
be more
basically, guys,
advanced.
the whole reason why Tarun is taking the time to explain everything in detail, even though we are not in a position to do some of those things, it is good for us to know how things are being done, because that helps you to create a better patient journey in terms of you managing the patient. Your patient might be dealt by few clinicians, but you will be the point of contact. So having a good knowledge base from the beginning will enable you to explain what the patient journey is going to look like for patients as they go forward. I think, does that make sense, Tarun?
Yes, of course. Even though if you're referring the patient, you need to have an idea of what kind of treatment is possible by a specialist, what kind of treatment planning is going to do, because most of the time the specialist will, talk to the referring dentist, and this is how I'm going to handle. So if you're knowing what the specialist doing, it creates a better journey for the patient and yourself till the end. So that is why it is important to understand one thing, and especially if you are a general dentist and you are going into implants, it is important to know what is the plethora of technique, what you can achieve, what are the different things, what you can do, what is the maximum what we can gain. So that is why I'm showing all these things, because you shouldn't tell, okay, I don't have bone, I'm going to do a bridge there. There is all the way to do reconstruct the bone to place the implant. So we need to understand where and what can be achieved with these techniques.
That's a very good important point, Tarun. Yeah, you can carry on. Thank you.
Sorry,
Yeah,
Tarun,
yeah.
before you start, there's one more question has come.
Yeah.
Neetu is asking, is any particular indications for tunnel technique?
A tunneling technique is basically when you are doing a flapless implant placement, especially guided surgery. So, and it is basically where you are doing just a contour augmentation. You're not having an implant exposed where you are not dealing with the sandwich technique. You are just putting one graft material into that space. So that is where exactly it is indicated. Even you can do a staged tunneling technique. If you're not placing an implant, you just create the tunnel, pack the graft material in that space into the tunnel, come back after 6 months and place implant. Even that can be done. So multiple indications of doing a tunnel, but if you're doing simultaneous implant and grafting, a tunnel is indicated only for contour augmentation. That means just to build the bulk of the bone.
Sure. Okay. Just follow up with just one more question. Ajay is asking, should we do use PRF after every extraction?
No. It is not that every time you do use a PRF. It is just if you are using a graft material, you can use a PRF as a plug. Not just a PRF in the socket is not going to gain anything, because I showed one of the cases, classic example of resorption. By just putting PRF, you're not going to gain anything in the socket. You're still going to have resorption, shrinkage, and you don't have any bone when you come for implant placement. So PRF is just an adjunct to all the procedure. It is an adjunct. It is not that without that we cannot do it. But along with that, we might get some of the growth factors to help in faster healing and improve the quality of the soft tissue healing, what takes place.
Okay, guys, I think we should carry on now. I think it's starting to get a bit.
Yeah.
All right.
Now let's see some vertical cases. Now you see that once we open the flap, buccal plate is gone, palatal plate is gone. So again, a video of periosteal release, how we do the periosteal release. I have already shown you just the bevel. I just want the importance of periosteal release, just the bevel. And then we place the implant. And you can see this is how an autogenous bone is taken from the anterior palate using a trifine drill. So you can see autogenous bone comes out in the trifine, and we collect this autogenous bone to do the sandwich grafting. And you can see here, palatally the implant is exposed, buccally the implant is exposed. So we use the sandwich grafting technique, but the membrane is different here. We use a non-resorbable membrane so that we hold the space for longer duration of time. 6 months later, come back, you have complete coverage of that exposed surface. Now what you will see is these are the particles of xenograft. You see that particles still exist. This is what is the problem with xenograft. After 6 months, you are still having the particle. It takes a long time. So imagine if you have filled it with the socket. In the socket, if you fill only xenograft, and when you come back to drill after 4 months, you will not have sufficient vital bone there. Here it is okay. It is going to remodel further till when it is loaded, because my apical portion of the implant is integrated and I can just go ahead and allow it to remodel. But when you are putting in the socket, your whole implant is in contact with the xenograft. Think about it. And here you can have that nice soft tissue is there, nice bone is there, and 3 years later, this is how it looks. Beautiful soft tissue profile, beautiful maintenance of the soft tissue. Both vertical, horizontal, which is managed with simultaneous grafting technique. Now let us see a staged combination defect, which is both vertical and horizontal, which is the last thing you can think of doing, especially in the anterior maxilla if you want to go for implant. You can see that there is absolutely no bone to place an implant. There is like a paper thin bone, vertically deficient, and you can see the same CAT scan. You can see that it is just a millimeter of bone. So we go with the GBR procedures, or you can do with the block graft. This patient prefer to do a GBR technique. So you can see here, there is how thin the bone is, vertically deficient in one side. We take our autogenous bone chips, use a 3D printed model to shape our PTFE membrane. And then the same thing, autogenous, 50% of autogenous and 50% of xenograft. And we place this PTFE, which is shaped in the 3D model, 3D printed model. And then we place this xenograft on top of it, cover it with PTFE. The vertical component is taken care by PTFE. And the horizontal component, I will bring my collagen back. Okay, I use the collagen here for the horizontal component. And then I use PRF to wrap it around, and then closure. For all this, this is the most important thing. You need to have a passive closure for all these things. Otherwise, your PTFE titanium mesh gets exposed like this. Come back after 9 months of healing. Open the site. This is your PTFE. Remove it. We have good bone. We have bone to place implant. We go with the guided surgery, place our implant. But remember, this bone is going to remodel. So I'm going to do one more round of contour augmentation onto these implants. And as I told you, the minimum thickness, what they found, if it has to have its vascularity, is this 1.8 mm thickness of the bone. If you don't have that, it is going to go away after some time. So here you can see the framework and the final restoration of this patient. And this is how she walks out of once final treatment is done. So in all, do we have sufficient literature for this technique, GBR? Now, if you see and find the literature, GBR is one of the most well-documented procedure to regenerate bone around implant by this article by Tara Glue and Peter Moy. And if you see the success rate of this technique, again, by Chipasco's review of literature, he finds that GBR can give you success rate of 60 to 100% and survival rate of implants 92 to 100%. You can be thinking, God, 60% to 100% is a long variation of success. Now, that is why I told you need to develop techniques, not just to go and learn, okay, I will just put this xenograft on top and then put a membrane on top. It doesn't work in all the scenarios. You need to classify defect. You need to understand what defect you are handling. And accordingly, you select your graft, accordingly, you select your membrane, then your success rate goes up. So in conclusion, what I would like to say is there are many techniques you can use for bone augmentation. You have ridge split, expansion, GBR, block graft, etc., etc. But all this works, but you need to understand what you can do and what works in your hand. And for that, you go enhance your skills by learning, and select technique which is least invasive and most documented. And you need to be evidence based to give your treatment plan uh, for the patient so that you achieve the best result for your patients. With that, I would like to conclude this and take some questions, and hope we had covered a bit of this stuff. It's a long 1 day lecture for GPR actually.
Man, amazing, amazing, amazing. I'm seriously, seriously so enlightened today. I don't know how you could manage to put in so much stuff in this 1.5 hours. I think it's more or less a whole MSc. But it was amazing. It sort of covered a whole lot of issues for people who are thinking about sort of pushing themselves, pulling their socks as they go back, have just been doing general dentistry and want to get into the next level. It's given them a very nice platform to see how they can progress, why it is so important for them to progress, and how easy is the pathway for someone to take. We at Dental Routes are conducting some introductory dental implant courses for people who are interested, and some of the people who have already been in the courses are there today viewing this webinar from Dr. Tarun Kumar, and it is a very, very practical based approach that we have been trying to emphasize, because that's the way forward. Having said that, Tarun has sort of covered the whole aspect in a wonderful way. Thank you very much, Tarun, for your time today. Going further, before I could take a few questions, I would just need to tell all the viewers today, because as I explained you earlier as Tarun was doing his webinar, a few things about flap design and suturing technique. These are the two very, very, very key skills that any of the people should have when they're getting into any kind of minor oral surgery or dental implantology. And for the specific reason, we have kept the whole webinar based only on contemporary flap designs and suturing techniques. It is dealt by Dr. Darshan Boindala. People know he is one of the directors at Dental Routes, and is a very, very well-known dentist and oral surgeon based in London. So he'll be going through all the stages of different flap designs and suturing techniques, the pros and the cons, and that will be on the 25th of May, if I'm right. That is this Thursday. Yeah, and that's exactly at the same time at 3 o'clock UK time. Guys, please go ahead and then register for that on the website, so you keep your place. And also for all the participants who want to have a CPD for today's webinar, all they need to do is to go back into the website. There is a section where they answer all the multiple choice questions. You basically click the same button that you click to join to attend, and you will be able to put a feedback. Your feedback is very, very important to us, because we try to take every feedback that you guys give, work really hard to make sure we keep on coming back with you with the best amount of information from the best speakers like Tarun Kumar himself. There might be a few issues with the certificate generation. Don't worry about that at all. Leave it to us. Even if it's not generated, we will make sure we'll send you back a link on your email where you can download the certificate. Having said that, I would be very, very happy to put some questions across to Tarun. I think we answered most of the questions while we did the webinar ourselves. But Tarun, as we go forward, once someone wants to start a sort of a journey towards going to dental implantology, would they have to start to look at how they do their extractions, how they're going to now start to look at doing extractions in the least invasive way, in a very atraumatic way, and then start to get into a very good training program which is more practically based? Is that what you would say?
Yeah, of course. When the general practitioners, when we are getting trained in our graduation, we know that what we are taught is basically take your forceps, go down on your bone, and then you give a buccal motion, lingual motion, a parietal motion, and then remove it with the buccal pullover. So basically, you are going to remove that bone. That is what we learned, and that is what we followed before we started doing implant, every one of us. But now we know that that buccal bone is so important. We should be very atraumatic. So what basically is learn the surgical techniques. When you go into the implantology, it is not just putting that implant, as I told you. It is about learning all the surgical steps. Learning all the next webinar is fantastic. You have flap management and suturing. It's such an important thing, because that is where everything starts for implantology. And after learning that, they're going to go and do a basic course where it is more of practical information of handling all these things, learning what is an implant, how do you manage the surgical procedure, asepsis, everything. So basically you go and enroll there and learn the basic and go stepwise, have a learning curve of stepwise going from one level to second level, third level. And that is what you need to do from. And I think that for any general dentist, moving forward, implantology is one thing which we cannot neglect. It is going to be one of the techniques for replacement of the teeth, which is of the future.
So guys, whoever is interested in getting into dental implantology, who want more information about how to get into the basics of dental implantology, whoever is based in the UK, please contact us at hello@dentalroutes.org. We'll give you enough information on that basis. And for people who are abroad, and especially in India, and Tarun is a speaker worldwide, and he runs a lot of courses. If you need further information about any questions you have, please email us as well. I'll be able to get those answered via email or by other means, okay? One other question that's come up as we sort of start to get closing up, because it's a very long session, is why can't we do decortication in every case, Tarun?
You can do it. We can go and do decortication for every case, but maxillary doesn't require decortication because it's more porous bone. Most of the time, you can see that pink color bone. So you usually don't require decortication in the maxilla, but mandible for sure you need to decorticate. So in my cases, what I see is how the quality of the bone is. The color of the bone indicates what is the quality of bone, whether I need to do a decortication. It is a white, thick bone. What we see in mandible, that means it needs to be decorticated. Whereas maxillary bone, if it looks pink color, it's oozing blood, it doesn't require, because of something called as rapid accelerated phenomenon. There is an initial resorption which takes place when you drill the bone, and that will itself take care for the vascularity to come in.
That's amazing. That's amazing. So guys, I think Tarun is just like a gold mine. The more you dig, the more you get, and you get in heaps and bounces. But unfortunately, with the amount of time we have, we need to bring it to an end. You guys have been so patient, and such a big session. It was supposed to be an hour. I think, guys, it's lasted for more or less 2 hours now. And I hope you guys enjoyed it as much as we did organizing it. I thank a lot from the bottom of my heart to all the panelists, which is Dr. Senthil and Dr. Jay, who has been handling everything from the background, Dr. Darshan, who has been managing all the technical and educational details from the back end as well, and our technical and IT team. And a very, very special thanks to Dr. Tarun Kumar. You have been amazing today. I don't know how much
Pleasure is mine.
No matter how much I do, it's still less. And also, we from the UK are going to be looking at how you guys are getting into the front line from tomorrow, I think.
Monday we are going to go in.
From Monday, yeah, that's something that we'll be looking at very, very closely from the UK. You guys are going to give us more feedback on how things are working and what the situation are going to be like. And we wish you all the best towards this next phase of the COVID-19 journey that we all are going through.
Oh, thank you, Kaushik. Thank you. Let's hope that's a good.
Tarun, it's been an amazing presentation, and it's such a complex procedure. You've broken down into bite size, and I think anybody who wants to get into implants, it's a great oversight of what can be achieved. But thanks a lot. Thank you very much for this.
Thank you, everybody, and thank you all the viewers. And we will be back with you on the 25th, guys, at 3 o'clock. So just don't miss it. Put it onto your calendar, and we'll be looking forward to see you guys again.
See you guys.
Bye now.
Bye. Bye. Bye.